Hi, I'm Neil Reddy, and I'm a medical oncologist who specializes in lung cancer at Duke University in Durham, North Carolina. Today I'd like to discuss the question, is there a role for using combination checkpoint inhibitor therapy in performance status 2 lung cancer patients? This is a summary of trials studying chemotherapy in lung cancer patients with performance status 2. It shows that for selected patients, both singlet and doublet chemotherapy can be safe. Further, it shows that in some randomized trials, doublet chemotherapy was more effective than single chemotherapy. There are a few trials studying performance status 2 lung cancer patients with immune therapy. Here is a phase 2 trial studying pembrolizumab in performance status 2 patients. It shows that the toxicity is similar to what one would expect for performance status 0 and performance status 1 patients. There is encouraging survival with a progression-free survival of 4.4 months and an overall survival of 9.8 months. CheckMate 817 is a large phase 2 trial. A major cohort in this trial looked at special populations. The main segment of the special populations was lung cancer patients with ECOG performance status 2. Patients received nivolumab, 240 milligrams IV flat dosing every 2 weeks, and ipilimumab, 1 milligram per kilogram IV every 6 weeks. This is the same regimen that was studied in CheckMate 227. This shows the toxicity profile for patients in 817. You can see the blue columns are for the CheckMate 817 special population. There were 198 patients. Most of those patients were performance status 2. Comparing the toxicity to the other trials that include CheckMate 817, performance status 0 and 1, CheckMate 568, which was a large phase 2 trial, and CheckMate 227, which was a large phase 3 trial, the toxicity reported for the performance status 2 patients was very similar to that in performance status 0 and 1. This shows efficacy. So the panel on the left shows response rates, which were very respectable in the special populations group, and the duration of response was excellent. There was a very reasonable progression-free survival for this group of patients. And this slide looks at biomarkers. So as is often the case, there was a high level of benefit in terms of progression-free survival for tumors that had a very high PD-L1 score. And there was also improved progression-free survival for high total mutational burden. These are interesting exploratory results in this large phase 2 cohort. So, conclusions. Is there a role for using checkpoint inhibitor combinations in performance status 2 lung cancer patients? So first, systemic therapy is appropriate for many lung cancer patients with performance status 2. For patients who have an actionable molecular alteration, such as an EGFR mutation, they should receive oral molecular therapy. For other patients, singlet and doublet chemotherapy is always a reasonable therapy option. There is phase 2 safety data for pembrolizumab in performance status 2 patients that shows good tolerance with toxicity similar to that for performance status 0 and 1. And there's promising efficacy data. In a large phase 2 cohort, the safety for nivolumab plus ipilimumab in performance status 2 patients was similar to that for a large cohort of patients who had performance status 0 or 1 from CheckMate 568 and CheckMate 227. The phase 2 efficacy for nivolumab and ipilimumab in performance status 2 patients was promising, with a good response rate in long duration of response. Surprisingly, there is little or no published data for the combination of chemotherapy and immune checkpoint therapy in performance status 2 lung cancer patients. I could not find any data in the literature, and when I checked with my partners, they were not aware of any presented or published data. So, in summary, Selected performance status lung cancer patients can benefit from systemic therapy. Chemotherapy, single-agent PD-1 checkpoint therapy, and nivolumab and ipilimumab combination therapy were safe and feasible for the performance status 2 lung cancer patient population. In these patients, therapy should be chosen based on patient history, patient preferences, and best available data at that time. Thank you very much for your attention.